Hey, folks, welcome to another edition of Broken Brains with yours truly, Bruce Parkman, sponsored by the Mac Parkman Foundation, a show where we look at the issue of repetitive brain trauma and its impact on our children, athletes, professional players, and our veterans. And we go out there and we find the most amazing people that have either gone through these ordeals or are working with the ordeals or on the research and science side. And we bring them all to you so that you become informed on the issue of repetitive brain trauma, whether it's repetitive head impacts or repetitive blast exposure, so that you can be informed. Because what we know right now is our community is not informed. And this is an issue that affects all of us across this country. Today, we have Dr. Sasha Blaskovich, and this is going to be an exciting conversation because he's on both sides of the deal. He's also not only a doctor, he's also been through this as a football player. But he's a board-certified chiropractic doctor who specializes in assessing and treating head and neck injuries. He's played football for over a decade, and he's been working with injured patients for over 20 years and has extensive firsthand knowledge with about every possible condition, pain, and trauma associated with the head and neck, which we all know are the primary causes of the issues that we discuss on this podcast. He's devoted his career to helping people going through the same problems he has because he has firsthand knowledge as somebody that's played professional sports. And he's obtained his doctorate of chiropractic from the University of Western States and has a Bachelor of Science from the University of Calgary and a doctorate in podiatry from the Netherlands. And he's helped many professional athletes, from football players to NHL players, overcome their injuries and sustain their ability to perform at a professional level, or help them when they've left the professional leagues. Dr. Blaskovich, thank you so much for coming on the show. Really appreciate the time today.
Thanks for having me, Bruce. Really appreciate that intro. That was quite extensive.
Hey, man, Denny doesn't mess around, man. He gets it all to me right there, right now. No, but we're all about head and neck, man. We're all about why are you focused on this trauma? I mean, obviously, tell us how you got involved. So it looks like you played a lot of sports.
Yeah, absolutely. I was playing quarterback and I threw the ball down the field and a linebacker came through a gap and basically just tied my arms up, and I was admiring my throw as it was going down the field. And we just landed backwards and my head hit the ground and he landed on top of me. It wasn't much of a hard hit, but it was just the way that I was not properly prepared for that impact that, I got my bell rung and, it was diagnosed as a concussion. But fast forward 30 years now, I realized that when that head impact happened, when I hit the back of my head on that hard ground, that there were shear forces that occurred between my skull and my upper neck that actually severed a couple of ligaments or severely stretched a couple of ligaments that basically act to stabilize my head on top of my upper cervical spine. And so for the longest time, the working diagnosis was concussion, but it turns out that what happened is I actually had a severe sprain of the ligaments in my upper neck that rendered my upper neck unstable. And by that instability, the extra shift that happens in an unstable upper neck tends to irritate and repeatedly stimulate the brainstem and also block off some of the drainage that the brain makes as far as fluid that's got to go down through the upper neck and bathe the entire spinal canal. And so that causes a back pressure up into the skull, which then poses brain-like symptoms, but the actual origin of all that is not actually a malfunction in the brain. It's a glitch in the drainage system between the brain and the neck. And so that's kind of what I've discovered on myself, first of all. And it's a dynamic process, so it's not always as irritating to the brainstem structures as other times. And there's many factors that, would probably take an entire day's lecture to go over. But bottom line is that the upper neck seems to be the massive missing link in these concussive-like diagnoses where all imaging and all examination procedures don't actually show anything objectively on the brain. That this has been, in my opinion and my experience, the missing link in those cases where all efforts were put on discovering what's wrong with the brain, only to find out that it's actually the brainstem region that's being irritated, causing a back pull up into the brain, rendering those symptoms, but that's not the origin.
Now, what is that focal point in the neck? I can't remember there, or from the chiropractic perspective.
Craniocervical junction is what it's called.
Yes, sir. And we've had, we had a meeting that I went to where a chiropractic doctor was, they actually have a machine, I guess, that can, target that area. Are we talking about the lymphatic system and and as that part of the brain, or what fluids right now, when you get that kind of a concussion, are being blocked so that our audience understands that?
Sure,
And
it's
how does that impact the brain?
sure, it's the flow of cerebrospinal fluid. And
Okay.
so
CS.
ultimately, lymphatics will get affected, but the main vessel that's involved here is the formation of the cerebrospinal fluid, which the brain makes inside the center of it. And these structures called the ventricles, they're basically caverns. And inside those caverns, the amount of blood or plasma from the blood that gets across what's called the blood-brain barrier dictates how much CSF, cerebrospinal fluid, the brain will make in those ventricles. And then the equivalent amount that's made has to drain through the upper neck in order to keep a balance or equilibrium of how much is made to how much is drained. Because if you make more than you drain, that means that you continue to make and it starts to pool in the brain. And what ends up happening as a first course of events is that the ventricles will swell out a little bit. And as they start to swell, they start to seep out some of the cerebrospinal fluid into the brain between the skull and the actual brain. So you have what would be termed hydrocephalus, but it's rarely diagnosed as such. And so, but it does cause pressure on the brain, which can result either in cognitive, difficulties and or just a simple headache or constant pressure in the head or pressure in the ears or, blurry vision. It can cause a gamut of things that aren't truly being caused by a defect in the brain, but it's caused by a backpooling of fluid that the brain is making as a result of our blood circulating nonstop and forcing then plasma across the blood-brain barrier, and then the ventricles make an equivalent amount of CSF as to how much plasma has been introduced to them, and then that has to go into circulation. And if more is made than is drained, you get a backpooling, and you can get a whole gamut of problems. And in a long-term trajectory pattern, if that is long enough standing or recurrent enough that it repeats itself often enough and frequently enough, you can actually get hypoxia or a reduction in oxygen and nutrients to the adjacent brain tissue that's right outside of the ventricles. And so an example, you'll see that when people get discovered or they get diagnosed with multiple sclerosis, inevitably, if you track the research, the vast majority of their so-called white plaques are periventricular, which means they surround the ventricles, which would pose the question of, is that because these ventricles are swelling because of this phenomenon that I just explained, causing then those adjacent brain tissues adjacent to the ventricles to be squeezed a little bit and voided or devoided or reduced in how much oxygen perfusion gets to those tissues, and they go into a different metabolic state, which can change their appearance on an MRI from gray to white or whatever the signal sequence is that they use it on MRI. So it'll show up as a sclerotic plaque, and the assumption that I always had is that that's dead brain tissue. Well, research has shown that if you can alter the fluid dynamics, some of those white plaques will dissolve and disappear. And does that mean that they were dead? That likely means that they were in a hibernative state, causing their morphology to change, which gives them a different appearance. And then if you reduce the hydrostatic pressure on them, they get more oxygen and nutrients back to them, and they go out of the hibernative state and start metabolizing properly and change their color into what we would expect to see on an MRI scan.
So you're saying that, does this start at the neck? Because we know that when you have a concussion, you have inflammation, you have swelling, and in very, very pronounced cases, then you have that edema, you have that really that buildup in brain where they have to drill holes and relieve pressure.
Yeah.
You're talking about the same type of phenomena where you have pressure within the brain causing cognitive and behavioral deficiencies that's stimulated by damaging the neck muscles.
The neck ligaments.
The neck ligaments. Okay. All right.
So then the only recourse that the upper neck has then to maintain a proper alignment and stability would be the muscles. And the muscles can't invariably hold on to that amount of work and forces long term. And that's why we have ligaments. Ligaments hold our joints passively together, whereby there's some amount of movement, but not too much. And so, for example, when you sprain your ACL in your knee or tear your ACL, now your knee is deficient. It actually moves too much. And so the only worst problem that you can, have happen there is that eventually you'll have degenerative arthritis where they got to replace your knee. Well, when that happens anywhere in the spine, the spine's number one job is to protect the spinal cord and brainstem, and the skull's number one job is to protect the brain. When you have an infringement upon that capacity to protect, the thing itself that's supposed to protect can now be the thing that encumbers. So when you have too much movement between two spinal bones, those actual spinal bones that are intended to protect the spinal cord will now irritate the spinal cord because they shift too much. And they nudge up against the spinal cord, and any even hydrostatic pressure, so them just displacing fluid, which is a viscous fluid inside the canal, can actually displace the spinal cord. So you don't have to have physical contact of the bone on the spinal cord. You can just have an excessive pressure or displacement of hydraulic fluid in there that will stimulate the spinal cord, or in this case, the upper spinal cord, which is the lower part of the brainstem. And then you get what would be called cervicomedullary symptoms, which are, anything that the vagus nerve basically is involved in. So heart rate, blood pressure, temperature control, breathing rate, vision, hearing, the transmission of bowel movements, stomach acid, even some reproductive things are governed by that. And that's just to list a few.
So in your estimation, given the fact that, neck ligaments are, pretty much, well, I'd say the neck, right? Whether it's a concussion in football, hitting a soccer ball, being tackled violently in rugby, or, getting checked in hockey, right? Your neck is always at risk. I'm a front or row prop. I'm a tight head prop in rugby. And, that's why I got turtle. Everybody calls me the turtle. I have no neck, right? It's just I got a neck and I got a shoulder. So, what, in your estimation, how common is this injury in our athletes? Because everything that we're talking about that impacts the head impacts the neck. You can't get away from it. So, this seems like there could be a fairly common injury that is not being diagnosed when especially when we have a concussion.
Yeah, I think it's an extremely underdiagnosed and undiagnosed condition. I think on a daily basis, I'm so incredibly shocked to find out how many people out there have a variation of this condition, if you want to call it, and that would be dictated by the severity of their symptoms. But the percentage of people out there walking around, and it's not just from sports, is massive. I think it's the most massively underdiagnosed phenomenon as it relates to the concussive, the global concussive phenomenon, if you will. A concussion is I think a very vague term that assumes that it's all brain.
Too vague. Yes, sir. Yeah. We spend so much money. Yeah.
The frequency and the prevalence of this upper cervical, ligament damage to some degree and some variation is ginormous. I said, it ceases to amaze me as to how frequently I see this. And, sometimes people end up coming here 20, 30 years after the fact, and they've been chasing their tail for that long, only to finally get some answers. And in some cases, too little, too late.
So what's the means by which we can repair this, or how do you treat this? Is this all, chiropractic work? Is it manipulation? Is it drugs? Obviously not playing sports for a while. What do you recommend when an athlete comes to you and says, hey, I've been playing for 20 years, right? And and identify that, he's got ligament damage. What are the characteristics like? Do you run a blood panel? Is there a brain scan? How do you determine that, number one, you have pressure, and number two, that, and then how do you treat that?
Yeah, the problem with determining the pressure is that I don't think a normal has ever been studied. Like, they only study this when there's the obvious, like when you say that they got to tap into the skull to release the pressure. Those are the obvious cases.
Right.
And that's a needle in a haystack. The rest of the people don't really fit that criteria. So their symptoms are vaguer and much less obvious. And especially when it gets into the chronic phase where they've been dealing with this for, decades, that the diagnostics of figuring that pressure component out are subjective. So you'll have 10 radiologists sitting in 10 different rooms, and they'll all have a different opinion on whether they think it's hydrocephalus or not. But at the end of the day, MRI scans, CT scans, regular x-rays, they will generally show subtleties that indicate that the upper cervical spine has somehow been compromised. Whether that's the peg that belongs to the second cervical bone is not perfectly centered where it should be, it's off to one of the sides. And that'll be deemed generally by radiologists, again, as a normal variant. And unfortunately, it's rarely a normal variant, if at all ever. And so picking up little things like that and then combining that or correlating that to the clinical symptoms that the patient is talking about. If they're saying they got, persistent headaches, they got blurry vision or double vision, they got fullness in their ears, ringing in their ears, their heart races when they're not exercising, they're having breathing difficulties, they're having digestive issues, they're having temperature control issues, irritability, forgetfulness, mood swings, you name it. There's, probably another 20, 30 things that they could possibly have. Then you combine all those things together and say, well, based off of the injury that you had and how you explain the event happening and the chronicity of what you've been going through and some of these subtleties on the imaging, it's highly likely that you have damaged ligaments. And if at that point in time, the gold standard for determining whether they do or don't is to actually do dynamic x-ray, which is literally moving x-ray. So they'll go side to side with their mouth open. They'll bend their head up and down so that you can triangulate, and they'll do rotation as well. So you can triangulate in 3 dimensions which ligaments, whether left, right, both, front, back, were compromised or are compromised, showing the instability. And at that point in time, there are a few different things that can be attempted. For example, if it is assumed to be just a positional thing, so that the upper neck bone or the atlas is out of position, causing a long-standing, what we call a functional stenosis. The bones are supposed to line up like that, but if one is slightly offset, it reduces the internal diameter at the junction point of those 2 bones. And as the simplest form of trying to correct that is a upper cervical chiropractic technique, which there are several of, that would then push that back into alignment in a very benign, non-forceful way, providing then a reopening of that canal as those 2 bones meet, and a person shouldn't have a reduction in symptoms. If they actually have instability that's pathologic, that correction won't stay. And they'll say that, your adjustment's not holding and it's repeatedly not holding. And what that means is that they likely have permanently damaged ligaments, which would not allow for that to be held no matter what you do to it as far as adjusting and realigning. And at that point in time,
yeah, I'm sorry.
Sorry. And at that point in time, you have then this neuromuscular system that I explained earlier. When the ligaments are permanently damaged, so like the ACL in the knee, anybody who's damaged their ACL and either knows or doesn't know about it, all they know is that they have perpetually tight hamstrings, a perpetually tight calf, and perpetually tight quadriceps, because they're all trying to compensate for this joint that's moving too much. And so in the neck, the same thing happens with the neck muscles. And what you can do is basically, as those muscles cinch down and go into a sort of really contracted state to protect themselves, but also to protect that extra movement that's happening, you can actually expedite their return back into function by just doing acupressure or ischemic compression on them, which means pressing and holding and squeezing everything out of them, so that when you're done squeezing, the only thing that gets into that voided muscle tissue is fresh blood full of nutrients and oxygen, and you've now reset that muscle and its ability to basically govern the bone or the upper bone going out of position, and it pulls it back in. So then when this is happening dynamically, it goes out of position, the muscles sense that and they pull it back into position. And then you go through your day and it goes out of position, the muscles sense it, they bring it back into position, but they can only do that for a perpetual amount of time. And at that point in time, they'll seize. And so the technique that I use on myself, generally on the vast majority of my patients, is this ischemic compression or sustained pressure technique, which then resets the muscle interface, the nerve muscle interface, so the muscle can actually sense itself being pulled out of position and then pulling the bone back into position. But that needs to be repeated sometimes multiple times a day or very frequently, so I can teach patients how to do that themselves. So the first, like I said, is the atlas adjusting, and assuming that the adjustments don't hold, you've got this neuromuscular technique, and assuming that either that's too much for a person to feasibly and logistically do, and or to go to someone to passively implement that on them from a treatment standpoint, like coming to me, for example. Their third course of action would be to do some kind of interventional or regenerative injection therapy, which is either prolotherapy, platelet-rich plasma, or stem cells, in an attempt to try to initiate some collagen regrowth in the fibroblasts that would be then either reproducing or correcting or healing some of the ligaments that have been damaged. So that would either thicken them or shorten them, reducing the amount of this offset that happens, and hopefully that'll last long enough where it'll be good for a long time, or they might have to repeat it in a year or whatever else. And if that all fails, assuming that all of the proper areas were injected, and that, again, is dictated by doing the motion x-ray and determining exactly which ligaments and where are damaged, so you can direct the injections to the proper spots. But if that all doesn't work, then the last recourse, especially if someone's having debilitating neurological symptoms that are, daily, would be cervical fusion surgery, where they basically go in and bolt together C1 and C2, in the case that it's just C1 and C2. And then that instability becomes immobilized completely. And these people generally get a new life if it gets to that point where, they'll still have pain and stiffness and discomfort, but, the nausea, the dizziness, the vertigo, the heart palpitations, the blurry vision, double vision, the cognition stuff all really goes away. They're just left with stiffness and pain in general after that, and some, fluctuating flare-ups of this and that. But the major neurological cascade of irritation goes away with the immobilization by surgical fusion of that area.
And I can understand, like, from a concussion, right? A one hit, or 1 or 2 hits, car crash, where this absolutely is something that needs to be looked at. And I can also see it for long-term athletes like myself that have been playing a lot of contact sports or been in the military over time. How does the issue of repetitive head impacts or repetitive blast exposure, where you have a damaged brain, okay, you have a damaged brain, that brain, is producing behavioral, cognitive, psychological disorders. Number one, how does that impact? I mean, it sounds like a question on the fluid, like when the CSF over time, does it have to be recycled like a lot, like when we have a concussion and we have all these, the chemicals, the endorphins, everything that's been released to deal with the injury to the brain, we do know that those chemicals over time become toxic, right? They start degrading the brain instead of assisting it because of long-term chronic inflammation. Here we have long-term chronic pressure, right? And in often cases, I would think we probably have both, right? If you have long-term chronic pressure from contact sports, you absolutely have taken thousands of hits, and now you've got a combination of issues here that both can be impacting, some of the overlapping symptoms that you said, the cognitive, psychological, some of these mood disorders, right? Depression. What are your recommendations for athletes that are, coming out, either, having pain, right? Or even, car crash victims, to go ahead and kind of separate where there is a history of repetitive head impacts and ligament damage? How do we separate the two so that they both get treated?
Well, first of all, it's cumulative. No matter whether you look at just the brain as an entity that's being injured, or the ligaments in the neck, anytime you add more fuel to the fire, you're going to have a likely progression of the problem, because it's a cumulative effect. So anytime you have repetitiveness, the likelihood that you're going to do a little bit more micro damage each time is highly probable. And when you go back to the pressure is inflammation, really. So it's not being called inflammation, but it is. And so what hasn't really been looked at is this, this notion that inflammation is determined to be present in the brain with a brain trauma, but the swelling inside from the extra fluid is a mechanical pressure that is an inflammatory process that isn't necessarily chemical, but it does come with a chemically mediated component. But that hasn't really been studied. Is that this, is there actually inflammation on a microscopic level? Maybe. But is the inflammation possibly being caused by an overall increase in pressure in the entire system, causing actual mechanical squeezing of the brain tissue, causing the inflammation on a microscopic level, resulting in the thing that you see, you get diagnosed with or you see? That hasn't been studied. And I believe that's a huge component of the inflammatory process, because we know that when you squeeze any other tissues, whether it's muscles or whatever else, as they start to basically be starved off of the proper supply of oxygen and nutrients, they start to break down. So you have the breakdown products, which are inflammatory in nature chemically, being displayed in an area where you simply have mechanical compression. And so the same thing I would propose would be happening, or could be happening, in the brain, that you have simple mechanical squeezing of the tissues. And as they start to become hypoxic or anoxic, their breakdown or their change in metabolism could release inflammatory chemical products that could be, sensed, that aren't really that the tissue itself is breaking down, but it's being squeezed into a hypoxic state, which allows for these, acidic products to be present in the area when tested for.
And we do know that, inflammation in the brain does deprive, the long-term inflammation deprives, blood, oxygen, nutrients, everything that the brain needs to heal. And it's that chronic state of inflammation due to those repetitive impacts that is driving that. So now, from your perspective, if we can get the atlas, joint, tightened up, we get it straight. Does that allow the fluid to drain? Then does that release the blockage? So
It does.
Okay. So is this something that any chiropractor can perform, or do they need to be specifically trained on this procedure?
Sure. The upper cervical adjustive procedures, so where you're just realigning the atlas, there are a few more well-known chiropractic techniques that specialize in that. Probably the most common one would be NUCCA, N-U-C-C-A. So there are chiropractors that finish chiropractic and do extra training and lots of extra training in how to implement NUCCA, how to properly triangulate the position of the atlas so that they can position it back into place in 3 dimensions according to the imaging that they perform. And another variation off of NUCCA is done with the hands, so the doctor does it with his hands. And then you have atlas orthogonal, so basically atlas again being the top neck bone, and orthogonal simply means that in 3 dimensions they determine how they need to correct this thing. And then and they use an instrument to do that, which is an impulse instrument that isn't actually mechanical but more of a sound impulse. And then they have advanced orthogonal, which is atlas orthogonal with just a bit of a twist to it. And so those 3 techniques are probably the most commonly implemented as far as trying to correct the position of the atlas in a very scientific and 3-dimensional way.
Okay.
But the neuromuscular, yeah, go ahead.
No. I just remember when I went to the chiropractor and he would take my head, I could never relax, man. When he started snapping my head back and forth and hearing all those joints crack, I could not get, it was hard to relax. And so, but this is, it's extremely interesting because, of all the athletes that have played, all of them have to have, damaged ligaments. But let me throw something at you. What's your, you said when you went back, you got tackled, your head hit the helmet. Now we got everybody wearing these mattresses on their helmets that we know does nothing to stop the movement of the brain inside the skull. And I talked to one high school coach. He said those things cause they only had 1 concussion that they knew of. Of course, the kids never report 50% of them, but it was caused by that helmet hitting the turf and catching on something, that pad thing. What are your opinion on those things, and how do they impact the neck? You got a bigger area to hit. You got more. You got a lot of. You're adding surface and mass. I mean, and as a chiropractor, what's your opinion on those parts?
I preach that all the time when I explain my scenario. Is it okay if I get a model to just show you what I mean?
Yeah, go for it. Yeah.
So this is the upper neck right here. So we got the skull. Right here, we got the atlas, which is C1 and C2 here. So, for example, my hit. So this is the bottom of back of the head. So what you end up doing is you've got the head here, and if you look at where the neck is, so there's a gap between where the bottom of the skull is and where the bottom of the C2 is. Can you see that?
Okay. Yep.
So if I land backwards, which I did, and the back of my head is the first thing to hit the ground, it's wonderful that I have a helmet, which is really, it's a futile thing, because what that does is it takes, if I can hold this together, this bottom point of my skull right here, and now you're going to add whatever profile of helmet, which is going to be a gap of whatever. So now you've actually increased the surface as to where my head stops. So normally my head would stop here without a helmet. And then this here, so say the impact happens and I hit my head like this. So this stuff is going to shear down. So the head hits the ground first, but there's still momentum in my upper cervical spine. So it's going to shear downward like that. And that's where the ligaments get torn. Okay. And if you look inside here, so that tooth-like structure that you see right inside there.
Yes, sir.
So when the head hits and this stuff continues, you can see how that goes backwards into there. And what's behind that tooth-like structure is the brainstem. So the initial impact is that tooth belonging to C2, or this thing right here. Where are you? This thing right here. So that thing smashes into the front of the brainstem, causing this sort of concussive-like blow where you see an MMA fighter, or Sidney Crosby, even when he got clocked playing hockey, just kind of they're done, right?
Oh, like Tua Tagovailoa, he's been
guaranteed
he's got the whole reactive.
Yep. And you see them go into the fencer stance and do all these things.
Yeah, the fencer stance.
That's brainstem. So they say it's brain, but the writing mechanism is brainstem.
Wow.
And cerebellum. So that's a whole nother story. But you add a helmet to this whole scenario, right? So now the back of my head is not here, it's
Right.
down here. So now
So you
the
got
amount of shearing that can happen in these areas is much
is
greater.
more.
Yes.
And then with
So
a cushion, you're adding another 2 inches on top of that. So the head's hitting probably 4 to 6 inches.
Yeah, it amplifies that
Wow.
shearing. And the more you amplify the shearing, the more load you put on the ligaments and the more prone they are to failure. And when they
Dude.
fail, like any ligament in the body, which the ACL has been studied the most, there is no healing. So you could have scarring, but at the same time, if your ACL was, let's say, let's say it was 4 inches long, and when you tear it or sub-failure tear it, which means you don't fully tear it, but it's still, stretched out, it's at 4 inches and 3/8 or 4 inches and a half. So now you got a 3/8 or a half inch more play in the knee joint, and it's prone to partially dislocating or grinding up your meniscus inside there with time, whereby, that happens when you're 18, and by the time you're 40, you need a new knee.
Okay. Wow. I mean, so this is something that basically, if you've played a lot of contact sports, you should get, evaluated for. And
If you're having symptoms, if you're
yeah.
living with daily pressure in the head or blurry vision or irritability or forgetfulness.
See, that makes sense. Tinnitus, all those symptoms right there do make sense from a
Those
pressure
are
perspective.
all signs that the vagus nerve or the cervicomedullary junction region of where the brainstem meets the upper spinal cord are somehow being irritated or stimulated in a way they shouldn't be.
Wow. I wonder how many, you don't know how many veterans I talk to that have tinnitus. I mean, and we all assume it's from a lot of blast overpressure, loud noises, whatever.
Yep.
As a matter of fact, I'm giving a call to my friend right now. He's had these, he's been going to the VA for years for tinnitus that just will not go away.
Yeah.
And you remember that CEO of the major corporation that killed himself after taking some COVID shots, and he could not get his tinnitus drove him to the point where he took his life. And who knows what kind of inflammation could have been going on that, could have been a result of all that. So where's the research on this, Doc? I mean, you're making sense to me. I'm sure you're making sense to the audience. I mean, we've all in contact sports, had neck injuries, you can't play contact sports, any contact sport, even head and soccer balls, without shifting your neck and your head around because of the forces, the unnatural forces at play. And we love our sports, so we're going to keep playing sports. Got it. So, where's the research and science on this? I mean, is it, what needs to happen to make, obviously education's a big part of this, but, where's
let me start out by saying,
right
going back to the, where you're talking about the veterans and just the blast effect and all that stuff, where they're not being physically impacted. There's a vibrational frequency coming through the air and I'm actually doing this today from British Columbia in Canada, this podcast with you, and just out of Vancouver here, out of UBC, I think it was in the early 2000s or the late 90s, they actually did a study on the startle effect. So where you have basically a loud noise occurring, and these people would whiplash themselves just by getting startled, and that sort of initial startle response, they would actually damage ligaments in their neck by being startled. And that's why you have, for example, I remember also in the late 90s that some of the ZR1 Corvettes, their actual audio system, their stereo system in their vehicle, when it sensed a rear ender about to happen, it would turn up the volume of the music so that the actual, whatever the guy was listening to would get louder, so that he would be pre sort of engaged. He would be startled by the music, so that when he got hit, it wouldn't be as impactful to his spine in the sense of whiplash. So he was pre-prepared for it. So he's prepped for it.
What? So they were already like planning for car crashes when they designed.
Yep.
That's nuts, man. I didn't know.
And as far as research, I think there's very, very little research, unfortunately, in the correlation between what's being talked about in the brain and even the lower part of the brain, upper brainstem. So, we talk about the concussion and the CTE and all that stuff. Well, there's also a phenomenon called Chiari, which you may or may not have heard of, and that's where part of the cerebellum drops down into the opening of the skull and actually takes up space that only the brainstem should have inside that opening. And sometimes because of all those effects, the inside of the actual brainstem spinal cord swells out, and they call that a syrinx or a syringomyelia. And so these things, I think, are part and parcel connected to upper cervical instability, and that has not been studied. And I hope that it, at some point in time, soon starts to be studied more, because the tendencies that I've seen and the connections that I've seen between the upper cervical instability and these other sort of named conditions are very, very obvious. And as far as it goes with, the as I discussed earlier, sort of touched on earlier, MS, and the fluid pressure increasing in those ventricles, and the plaques being periventricular in most cases. A gentleman named Dr. Raymond Damadian, he actually invented the MRI technology. He was operating what's called the Phonar Corporation in New York, and Phonar has upright MRI scanners, and they designed proprietary hardware that is able to determine when the MRI pulses as the CSF is circulating. So they could actually find voids or flow voids, they call them. So where you see, for example, drainage tubes going up and down the front and the back of the spinal canal, where the one disappears as they're doing the sort of basically I'm yapping a lot here, but as the scanner basically is told to pulse a scan, it's when the heart pulses, as I was telling you earlier, our heart rate is in direct proportion or in direct sync with the rate of flow inside the brain and spinal canal. So every time our heart beats, plasma goes across into the ventricles then circulate CSF in there. And so he was able to determine or design this hardware product that measured a person's pulse on their finger with a pulse meter. And every time the heart beat, because it varies, it's not always, at so many beats per minute, it varies. And it was able to sense that and then tell the MRI scanner when to pulse a picture. And so they piece all those pulses together and they create a video loop, and it's called a Cine loop. And so what they showed is that a lot of people with MS have voids in their flow, whether it's inside the brain somewhere or in the upper cervical spine, and sometimes even in the mid-cervical spine. And by correcting some of these malpositions of the bones, they could repeat the CSF flow study with the upright MRI scanner and see that now you can see full drainage. And then they would also then rescan these MS patients and note that in some of the cases that the actual plaques were gone within 45 minutes.
And how were their symptoms from MS? Like
also reduced. Severely
man, I
reduced.
got a guy. I got a guy that I'm going to send to you, man. I mean, he's a good friend of mine, suffering from MS, and I've got him. Anytime I come across anything that can help him, and that comes to the crux of the problem here. I mean, Doc. I mean, you sound like you're out there. I had to write a book for parents because there was no guide on how much contact sports your kids can play. What are the risks to their health? And I got a dead son. He's behind me right now. And how much of this is just, the medical community not wanting to, the big battle between chiropractics and, chiropractors and doctors that went on. Now we have chiropractic care in our our troop medical clinics. We got chiropractic as an accepted, form of treatment right now. And it sounds like a lot of these, very, very severe issues. When you're dealing with blurry vision and tinnitus and dizziness and depression, and you got a busted up head, to think that you could possibly go to a chiropractor and spend a couple $100 and get your symptoms relieved and fixed is not what I think the medical community really wants to hear. But I think we're moving towards an age where, I mean, we got to get this knowledge out there. So for our audience here, is there like can they obviously if you could just go through the list of the symptoms that obviously you have to have played contact sports, or you had to had some form of neck trauma in the form of a concussion, and it could have been a long time ago, right? I mean, a car accident when you were a kid, something like that could still be affecting you to this day.
Yep. Again, it's progressive and cumulative. And so,
Wow.
to what you said, I also wrote a book and published it in 2019 that sort of really goes into, in a layman's way, this notion that the upper neck is connected to these things in a lot of cases, and it's called Dr. B's concussion breakthrough. And that's simply my story. I mean, I was diagnosed with a concussion, and it wasn't a concussion. I can stand behind that 100% that it wasn't a concussion. It was a concussive like blow, but my problem is in my upper neck. But anyways, it's called Dr. B's concussion breakthrough. I can't tell you how often I have people calling me or coming here going, and I whatever read that book or listened to it on audio. It was literally my story, and the more it's out there, the more I hear that people can really jive with that, because it's literally telling everyone's story that we go through, is that you have these these deficiencies and these symptoms, and you start having, problems with family and friends, and you kind of withdraw from, social
Yeah.
life and do all these things. And there's an absolute reason for that. And being able to put it in its place, knowing that you have a particular pathology. So for myself, it took me 12 years of self-searching and becoming a chiropractor, which wasn't the reason why I went into chiropractic. This happened as a dumb luck thing because I was already in chiropractic or going towards that. But at the end of the day, it took me 12 years to figure out why I was the way I was, and to come to grips with that, and that, to try to help my family also understand, why I am the way I am, that it's not that, daddy's always angry. Daddy's got this background noise happening in his head that, he can't get out of there. And the more he has time to think about it and dwell on it, the worse it gets. And so, when I got to go, hide for a half hour and work on my neck muscles so that it relieves the pressure in my head and makes me feel better, give me that half hour, and, and I'll be a different person, and I am. So that all that kind of stuff is in the book. And, my co-author and I, we drew on our dozen and a half or so things that we kind of, gravitate towards on a daily basis, not all at the same time, whether it's, breathing exercises, meditation, mindfulness, forcing ourselves to think the glass is half full as opposed to glass empty, like half empty, like all these things that are beneficial in their own way to helping us feel better about ourselves and be better people, are all in the book there for, anybody to freely read through and try on their own. It's really not rocket science, but the fact that we all look normal and look like we have all, everything that we should have physically, it's really hard for even our loved ones and doctors and other people to, come to grounds with the fact that we are actually broken on the inside. They just can't see it. All they see is the manifestation of either our anger or our, apparent disregard for, enjoyment of life and whatever else they might think. And we're all malingering, but we're not. And so to have, loved ones, learn this stuff beside the person who's dealing with it is of utmost importance, so that the support group is there and it's legitimized. And sometimes legitimization requires actually seeing that there's damaged ligaments by way of doing a motion x-ray, and seeing that there's physical hard evidence that explains why somebody's having brainstem like related symptoms, so that everybody can kind of put it in its place and support each other. Because at the end of the day, people are just genuinely good people, and they're brought to a point of frustration because either their own lack of understanding, or the lack of understanding of their loved ones, which they expect and feel like they should be entitled to have. And my turning moment was for me a couple decades ago, when I decided willfully to not let anybody feel sorry for me, and most of all myself to feel sorry for myself. When I got rid of that expectation, things changed dramatically, because I wasn't having background irritation and disappointment because somebody wasn't feeling sorry for me when I thought they should. I actually have an aversion to somebody feeling sorry for me when I'm at my worst, because it just puts fuel on my fire. I want to get better. I want to feel, more vigorous and vital. And for, to have somebody feeling sorry for me and saying, "Oh, poor you," that just makes me irritated. And so at the point in time where I decided to, to not let that be the thing, to not have an expectation for anybody to understand how I feel, because they shouldn't, unless they're going through that themselves, things became a lot better because my expectations were gone.
Good for you. And that's what we try to tell people is, like, mental health is our responsibility. And there are people out there that want to blame whoever, blame, whether it's the military, or blame, God, or blame, their
What's
parents,
done is
their
done.
childhood.
What's done is done. Yeah.
You've got the hand God gave you. Now, what are you going to do? Are you going to fix it? Do you care enough about people to take, hold and, I can tell my own story, the same thing, right? Just you fix yourself but I think what people don't know is that there's ways to fix themselves. And so when we are mentally ill, we think it's hopeless. Hey, I'm crazy. Like my poor son, right? He just thought he was nuts, I guess. And he had to leave. He didn't think he could ever get better. And that's why we have this podcast, let people know there's methodologies like yours. There's all kinds of hope out there in terms of treatment and supplementation and understanding and science now, that, mental illness that has a physiological cause, like what you're discussing, can be treated, can be improved. But you have to take those steps. You need to move out and you need to educate yourself, because, 95% of chiropractors out there are completely ignorant of what we're talking about right now. Just like most of the medical and nursing and psychiatric community has no idea that RHI and RBE, or neck ligaments can lead to cognitive and psychological conditions. We have an unbelievable amount of awareness to do and educate, and you're part of that. And I really want to thank you for that. Before we close, a little bit more. What's Dr. Blaskovich up to right now? How can people find you? What do you got planned next? You know, what's going on?
Every day is chaos. It's really crazy busy. I usually, you know, when people come and see me in person, they usually access me through whiplashclinic.com.
Okay.
And I have patients from all over the world that have learned from other people, word of mouth, that I have a unique capacity to evaluate their MRIs and CT scans and other imaging studies to look for things that the radiologists generally are not trained to look for. And even if they look for them, they would deem them to be normal variants, as I explained earlier. So people will then, you know, shift over to transferring me all their imaging for my opinion. And that goes through drblaskovich.com. So I started a special website for that so that people from all over the world, should they choose to, you know, engage me in trying to help with their situation as far as providing my 2 cents on something that has already been conducted with them, such as imaging studies primarily, then I'm happy to have a look at it. And what I do is I look at all their imaging and I annotate. So I draw up arrows and circles and whatever else on their imaging to point to certain areas of interest. And then I will explain that to them through a Zoom call so that they have a good grasp of what I was demarking on their imaging, and explain how that affects their neurology and likely is connected to their symptoms. And then hopefully they can take that and go to a local physician or specialist and hopefully get some direction there so that they don't have to travel all the way over to, you know, because ultimately the diagnostic component is the number one thing, and any kind of treatment avenue that you take is just icing on the cake. And unfortunately the system is put together such that they put treatment before diagnostics in 9 out of 10 cases. So they, you know, try a bunch of stuff and see if it sticks. And then if it doesn't work, and, you know, you might be 2, 3, 4 years further, they finally double back and go, well, let's go see what's going on inside. And so I want to make a push for reversing that so that the diagnostic component becomes of utmost importance and is done up front. And then after that, you can choose your direction more accordingly.
Well, Dr. Blaskovich, thank you so much, man. And you're right. I mean, why do we want to put treatment before diagnosis, right? It's just counterintuitive. We got to.
You wouldn't want to take your car to the mechanic and have them start changing things and going, we should change this and change that, only to come back and go, hey, you know what? Let's hook it up to the scanner now and see what we got to do. You'd be like, I'm not paying you a penny for that.
No, and that's how we do healthcare all the time, man. Yeah. Well, I can't thank you enough for coming on the show, folks. Dr. Blaskovich, really take a look at his website, drblaskovich.com. And don't forget your free book. Come to the website, download this for free, become informed on the issue of repetitive brain trauma and what you can do to help yourself, your children, and those you love. Dr. Blaskovich, thank you so much for coming on the show. Really appreciate it. To our audience, thank you so much for another great podcast of Broken Brains. We look forward to the next episode with you. Y'all take care and Merry Christmas.
Thanks, Bruce.